Right, our final talk this evening is from Matthew Hadfield, and Matthew is a fellow escapee from the NHS and is going to talk to us today about the regional perspective. He's currently, he mentioned earlier now, the Director of Medical Services at Ballarat, not just in charge of surgery, as also the chair of the RACS Vic State Committee. So Matthew's got all sorts of hats on at the moment and will hopefully give us a very interesting talk. So over to you, Matt.
Yeah, thank you very much. Yeah, I have probably too many roles at the moment and they need a little bit of rationalising. I'm also Deputy Chair of the Victorian Clinical Council, as well as Chair of the College Committee. Thank you for the invitation. When I was asked if I would talk on this topic, using VASM for quality and safety, a regional perspective, it's helped me pull together in my thoughts quite a number of ideas which have been rolling around for a number of years. Particularly, I'm interested in the fact that time and again, I hear, whether from individuals, from hospitals, from state, from national bodies, that we, Victoria, Australia, provide a high quality health service, a high quality surgical service. And yet, when I ask people, how do we know that we're providing a high quality service? There's a lot of silence coming back and no one can really answer that in any specific way. And so I personally think the benefits arising from use of the VASM database, as the example we're using here, are or should be clear to everybody. To use a database where the data is collected by clinicians rather than using administrative data, the relatively high compliance rate, the fact that it doesn't rely entirely on self-reporting, and the use of different reports, be they state level, hospital level, and individual level, all contribute to the multifaceted quality improvement programs that can stem from that. Now, regional view is in my title. Are there differences in the use and the usefulness of VASM in regional and rural settings as opposed to metropolitan, I guess? I believe that clearly there are. The surgical system extending out, particularly into the more remote areas of the state, is a very different beast to that within easy reach of Melbourne, with many, many single-handed or visiting surgeons who aren't in any small hospital on a permanent basis. And I think that makes things very different. So I guess first I need to clarify what I'm thinking about when I'm talking about quality, and the previous speakers have touched on this as well, that I think there's three aspects to quality within surgery. I think clinical effectiveness, that is giving care that's evidence-based and effective. Patient safety, so eliminating avoidable harms and risks. And then patient experience. What matters to the patient is really important. I also see that when we're looking at that, there's different measures are appropriate and speak to each of those subheadings. And whilst there's overlap, I think if we touch on VASM, it clearly slots into the patient safety area rather than anything else. What do we measure to look at quality? Well, my personal view is there is a tendency worldwide, not just in Australia, but equally here, particularly because there's a trend to use administrative data over and over again to turn outcome measurement on its head. And we ask, what data have we collected? And then we ask, well, what measures could we extract from that? And I think that's a really dangerous route to go down, rather than identifying a valid measure as clinicians and collecting that data de novo and using that. That's why databases such as VASM, which follow that route, move us all in the right direction. Now, to be somewhat controversial, I think personally that the sophistication of the surgical outcome measurements and quality improvement programs elsewhere in the world is noticeably higher than in Victoria or Australia. With systems that collect and report on a far wider range of valid clinical outcome measures. Now, there's two on the slide here. with the bodies that are responsible. So the UK have the Healthcare Quality Improvement Partnership, which is under the auspices of Combined Royal College of Nursing, Academy of Medical Royal Colleges, and National Voices, which is a patient body. Or if we go to the USA, NESQIP is the Quality Improvement and Outcome Measurement Program instituted and designed by the American College of Surgeons, which has now spread worldwide. I think the important thing for all those systems is that they all fall under the remit of the profession. They're clinically designed, clinically driven, clinically led. If you look at NESQIP, the American College of Surgeons designed this, set it up 20 years ago, and have supported it and pushed it so it's the preeminent quality improvement in surgery program within that country, and also within a number of other countries now. If you look at a different model, HQIP has been set up when the British government contracted out the responsibility for the design and running of a quality improvement program to the profession on a legal basis. They sit alongside the VASM type of database to demonstrate that the value of a clinically designed and run program is of the highest standard. I think personally we must strive to maintain clinical, in association with patient, decision making and design, and start from the bottom up. Design what we need to do, collect the data, and publish the data, which is somewhat controversial. Now, I'm talking about regions, so even in a small state like Victoria, here's my region, here's the Grampians region. This is a significant area. I sit in Ballarat, which is at the very right-hand end of that region, but within that area, not only Ballarat, but Daylesford, Ararat, Stawell, Horsham, Nil, there are a range of hospitals providing surgical services, all with different scopes of practice, and all which need some sort of outcome measurement and quality improvement process to provide the very best care. And finding a one-size-fits-all system is really, really tricky. How do I view that? Well, I've got two hats, two views, if you like. Sitting within the local hospital, my local hospital where I'm now Chief Medical Officer, I'm in a regional hospital, but to be fair, the big regional hospitals, whether it's in Ballarat, Bendigo, Barwon, they're far more like metropolitan, outer metropolitan hospitals than the rest of our colleagues further out in the region. And so our processes are very much like the metropolitan processes. If I look further west, the questions I've got is how can we support our colleagues out in the smaller hospitals further west to look at and maintain and improve in the same way? And also, I guess, because we're talking about VASM, what actually should we measure? Because especially in those smaller hospitals, there are very few deaths and the number of data points in the VASM database is going to be very low. What else should we be looking at? And that's a very tricky problem. What do we do within Ballarat Health Services? Well, I'm not going to go over the things we've heard again. In terms of the data we get back from VASM, we get the same data. We probably look at it in the same way as the big public hospitals, as the private hospitals. So we're looking at the clinical management comparisons. We're identifying places where we fall below our comparators, whether it's the unplanned readmissions at 77.9% versus 5.3% for state comparators, 4.1% for national comparators, unplanned returns to theatres, clinically significant infections. It seems that there are trends wherever you look, and those are key indicators. We use those as a starting point to look more deeply, and we implement audit and audit projects looking at unplanned readmissions, looking at unplanned returns to theatres in the same way you heard in the previous talk, and try and improve from there. What's the problem? Well, 166 fully audited cases over 5 years. The good thing about VASM is death is fairly binary, so sure they died, but it's a relatively small number compared to the throughput. So I believe that using this type of data coming back year on year guides us in the right direction. I have thought for some time we need more data collected in a similar way. As an individual hospital, we have chosen to invest and join the NESQIP program. So we have joined into the American College of Surgeons NESQIP program, sadly, because it would have been great had there been an Australian college program of similar sophistication and quality, but that simply doesn't exist at the moment. So we have invested time, we've invested financially. It's probably an investment of $100,000 to $150,000 over 3 years to join that NESQIP program and to submit data to that and to start to get peer comparison data back from that program so we can try and see how we perform. So it's more sophisticated data than we get from VASM, but it pushes in the same direction. And I think I think VASM and these databases are all working towards the same thing. And just so you've got some idea where we go, those are our VASM figures before. Here's the first 6 months within the general surgical field that we got back from NESQIP. They have an unusual way of presenting their data, but they give you quartile data and they show you where you sit within the quartiles. If you've got a red dot and red bars, you're not doing so well. I presented this data, and this is based on 342 submitted patients over a 6-month period, because it's a sample database, which showed that compared to the other 700 hospitals worldwide in the database, we sit in the worst quartile for renal failure, post-op UTI, surgical site infection, sepsis, and readmission. But actually sit spot in the middle for C. diff colitis and return to the operating room. So I presented this to the board at the hospital. They were slightly taken aback because, like many others, they thought we were doing really well in terms of quality. But actually, this is a starting point. This has given us something to aim at. We've started to look in detail at each of these measures, and we've started to put in place quality improvement programs unlike anything that we've had before within the hospital. And so I don't think we can be nervous about measuring and finding things that are bad, because we need to find problems if we want to improve. I spoke to one of my professors when I was a registrar over at the NESQIP conference in America, who said the worst thing you can get from submitting to such databases as this is the middle of the road result where you're the same as everybody else. You need to find things to improve on, otherwise there's no impetus to keep on measuring. Just so you know, the benefits of a database like this is there is a specifically employed full-time clinical data collector that is trained by the American College of Surgeons, collects according to their rules directly from the patient admission details contemporaneously, and follows up the patients for 30 days afterwards. So it is a very detailed program. What happens as you get further out? Well, you may have read the King's Fund report from 2015, which shows the picture emerging in Victoria of delivering good results in comparison with other parts of Australia, and being close to and sometimes above the average on many indicators. But the report was fairly vague on what those indicators were, and it didn't really reassure me reading through that it was telling the whole picture. It did note that for regional and rural health services, their isolation created risks in relation to the safety and quality of patient care. What else did we find? Have we seen about regional and rural centres? Well, Targeting Zero specifically mentions VASM. It also mentions that it's difficult for small rural organisations and health services to run adequate safety and quality assurance programs. It highlights the need for small, rural, and large regional hospital partnerships to improve that situation. And comments, in inverted commas, overwhelmingly the key issue in regards to clinical governance, and it's referring to the small rural hospitals, is the ongoing lack of engagement of visiting medical officers. And by that, it doesn't mean they're not interested. It usually means they're not there. And there isn't a 24/7 presence that can drive the clinical side of the issue. So where do we go? Well, as much as the Duckett report suggested regional larger hospitals partner with the small hospitals to provide a regional governance program, a regional M&M program, and a regional quality improvement program, there has been limited progress in that field. Part of the limited progress remains that the visiting medical officers have no time scheduled for these activities in the small hospitals. Part of it is it's difficult to tie together 5, 6, 7, 8 independent health services to come to any kind of clear decision, and the inertia is difficult to overcome. But if there's one thing I think we need to push forward with, it is that it's pulling together this group of hospitals to getting a supported quality improvement, outcome measurement, and safety program to improve the quality of the surgical services we can provide to our remote and rural communities. So I think we should touch on the issues we have to overcome, and these are issues with VASM as well as many of the other databases. There is always the question about data secrecy, data privacy, that the learning and improvement aspects of seeing this data are fine, but there is still the worry and the concern about blame and punishment, about if you publish data, you report it to APRA, and there's no control over that system. It is a common worry, an understandable worry. I guess at some point we have to bite the bullet and make the data public. Clinical performance indicators, if you look at Ben Bridgewater's papers from 2013, publication of clinical performance indicators leads to improvement in those indicators. Initial challenges to data validity. When we circulated our first NESQIP data reports, the overwhelming response, as it often is to new systems, is the data's wrong. It took some time to go through the detailed methods of data collection and bring colleagues on board, and now they are all on board. This is accurately collected data. Once you get that acceptance, then you push forward with quality improvement. And finally, I just want to push again my belief that directly collected clinical data in a system designed and controlled by the clinical professions is the way forward to get quality improvement. Thank you.